And I will now pass it over to Rob Foligno from SK Life Sciences to introduce our first presenter today.
Thank you, Jocelyn. Go Gators, by the way. I am a Gator as well, and we got a big game today, so beat the dogs. It's my privilege to introduce Dr. Andres Kanner, who is the director of the Comprehensive Epilepsy Center and the Epilepsy Division at the University of Miami Miller School of Medicine, where he's also a professor of clinical neurology in the Department of Neurology. Dr. Kanner joined UM 8 years ago from Chicago, where he had been the associate director of the Rush Epilepsy Center and the professor of neurological sciences and psychiatry at Rush Medical College. Dr. Kanner has been involved in research of pharmacological, psychiatric, and surgical aspects of epilepsy. He's board certified in neurology, psychiatry, epilepsy, and clinical neurophysiology. Without further ado, here's Dr. Kanner.
Good afternoon, everybody, and I'd like to welcome you to this meeting. I want to thank, first of all, the organizers for having invited me to this meeting. I always enjoy participating in these meetings where I'm talking to patients and families of patients and people in the community that are interested in epilepsy. I'm welcoming you to my virtual office in this time of where we have to do these virtual meetings. So I was asked to discuss an important question that unfortunately 30 to 40% of people with epilepsy ask themselves at one point or another, what do I do when my anti-epileptic medication does not control my seizures? And this is, next slide, please. Now, what are the important questions that patients and family members have to understand? The reason that people with epilepsy take medication is to achieve total seizure remission. And here the important concept is the achievement of complete seizure remission, because if people have one seizure a year or two seizures or three seizures a year, you still are limited with many activities such as driving, and that can impact on the quality of life. What is the expectation that anti-epileptic medication will stop all seizures? As I said before, is 60 to 70%. So in 30 to 40% of people, seizures will not respond to medication. And so the question is, where do we go from the point where we've seen the medication not stop the seizures? Next slide, please. The first thing is to understand, can we predict when anti-epileptic medications are likely to prevent seizures? And this is something that depends on the type of epilepsy. Some epilepsies respond better to medication than others. For example, idiopathic generalized epilepsy, such as juvenile myoclonic epilepsy, childhood absence epilepsy. Those are epilepsies where 80 to 90% of people will become seizure-free with medication. When you have epilepsies in the elderly, those people are more likely to become seizure-free. About 70 to 80% of these people can expect to respond to medication. And then there are, unfortunately, the types of epilepsy where medication is unlikely to stop the seizure, such as the Lennox-Gastaut syndrome. When people have focal epilepsies that are caused by what we call mesiotemporal sclerosis, that is a scar in the temporal lobe, in the hippocampal formation, the likelihood that people will respond to medication is between 30% and 40%. And some people have suggested that it's even lower. So as you can see, your doctor can estimate, based on your type of epilepsy, what are the chances that you may have of responding to the medication. Obviously, the medication has to be the proper medication for the type of epilepsy that you have, and it has to be given at optimal doses to achieve seizure freedom. Next slide, please. So a seizure, a patient whose seizures persist after 2 to 3 appropriate anti-epileptic trials at optimal doses is considered to be suffering from treatment-resistant epilepsy. Treatment-resistant epilepsy is a concept that we use to suggest that medications may not be the solution to render the person completely seizure-free. And based on multiple studies, the International League Against Epilepsy has concluded that the likelihood that a person may not respond, may not be free of their seizures with medications can be suspected after optimal tries with at least 2 to 3 medications at optimal doses. Next slide, please. Now, before we make the diagnosis of treatment-resistant epilepsy, we have to also revisit how the diagnosis was made, because it is possible that the diagnosis was wrong and that the person may not be suffering from epilepsy. And in fact, 1 out of every 4 to 5 people that we see referred to our epilepsy programs with a diagnosis of treatment-resistant epilepsy do not have epilepsy. They have other type of conditions that are not epilepsy and that require a different type of treatment. So it is important to revisit with your doctor, is my diagnosis correct, and can we ensure that I may not have another type of condition? The other the other question is the type of epilepsy that I was diagnosed with the correct type of epilepsy, and am I being given the proper type of medication for this type of epilepsy? Because there are some medications that work with some type of epilepsy, but not with others. And some medication can in fact worsen seizures in other type of epilepsies. So making sure that the diagnosis of epilepsy is correct and that the type of medication that had been tried is the correct medication for this type of epilepsy is of the essence. Now, there are certain type of epilepsies where even if you're taking the proper medication, your style of life may interfere with achieving a complete seizure control. And that is exemplified with certain type of epilepsy, such as juvenile myoclonic epilepsy, where sleep deprivation and alcohol consumptions can facilitate the occurrence of breakthrough seizures. The other frequent cause of breakthrough seizures, and this happens in all types of epilepsy, is poor compliance with medication. So it's always essential for physicians and patients to ensure that they're taking their medication as prescribed. Next question, please. Now, what are the treatment options when anti-seizure medications are not resulting in seizure remission? What can we offer patients? And luckily today we have several options that we can consider for these 30 to 40% of patients where medications have not stopped the seizures. One is epilepsy surgery. Another one is neuromodulation therapies. The third one is the use of special diets. And we, even though medications have not stopped the seizures, we don't stop trying other medications, including experimental drug trials, but we start at that point to consider the possibility of the person being a candidate for first epilepsy surgery, because epilepsy surgery is a treatment modality that can cure the epilepsy in people who had not responded to medications. Neuromodulation therapies and special diets are treatments that can significantly improve the epilepsy of patients, but are not necessarily curative. And the use of newer medications can often decrease the seizure frequency to a significant degree. Next slide, please. Now, what about epilepsy surgery? And this is sometimes a bit frightening for patients who say, what, you're gonna open my skull and take away parts of my brain? So let me explain what epilepsy surgery implies. We consider epilepsy surgery as an option in people where the seizure activity, the seizure focus, and remember a seizure is a short circuit. So the area where the short circuit arises in the brain is well identified. It's an area that is clearly localized with a series of tests that we have patients go through. And this is an area of the brain that can be safely removed. And again, here I emphasize the term safely removed with minimal risks. Now, there is no neurosurgical or surgical procedure that is completely free of risk, but here the key term is minimal risks. So the three questions is, does this person have a seizure focus in an area that I am clearly identifying? Is this area an area that can be safely removed? And are the risk minimal? If the person's evaluation meet these three criteria, then we can consider and offer the option of epilepsy surgery to these patients. The chance of seizure freedom in people who have intractable epilepsy depends on, I just lost the slide, depends on where the seizure focus is. The most frequent surgeries involve resections of mesiotemporal structures in the temporal lobe, and the chance of achieving seizure freedom range from 50% to 80%. Now, if you compare that to a chance of being seizure free just with medication when you not responded to 3 or 4 trials of medications of being less than 5%, you can see the advantage of having to consider that option. You have to also consider that persistent seizures can be associated with a worsening of memory processing, and in some people attention span, and some people with persistent seizures can see the development of depression, anxiety, and it affects the quality of life. All of these complications of epilepsy can be reversed with the cure by epilepsy surgery. And in fact, we've also seen that people with a history of depression or anxiety who have undergone epilepsy surgery, these depression and anxiety disorders may go away after they achieve a seizure-free state after a temporal lobectomy. The resections can involve any part of the brain as long as that part of the brain can be safely removed. There are certain areas of the brain in which that are processing vital functions, and in those cases, resective surgery or removal of the brain is not an option. And in those cases, we then consider other options. There is a new type of surgery, next slide please, which is called laser ablation, and this is done particularly in the temporal lobe structures. Next slide please. And this consists of using laser in small structures of the brain. In this case is in the temporal lobe, in the amygdala and hippocampal formations in the temporal lobe. And it consists of hitting those areas with a laser under general anesthesia and with a computer program that burns that tissue. Next slide, please. And it doesn't require opening the skull. At the end, you're left with a small 2 millimeters scar in the back of the head where the probe is inserted. The probe is, by the way, 2 millimeters thick, so it's a very thin probe. Next slide, please. And next slide, please. And at the end, this is the way the brain looks like. The area with the white rim is the area that has been burned. in the mesiotemporal regions. And this is the way it looks at 1 month. The likelihood of becoming seizure-free with this new procedure is about 50 to 65%. It is less invasive than epilepsy surgery. And here the key is the proper selection of patients. And we're doing it more and more in patients with temporal lobe epilepsy, or in patients who have small lesions in the brain that can be burned with this procedure with a good degree of success. But unfortunately, not everybody is a candidate for this type of new surgical treatment. Next slide, please. Now, what happens when a patient is not a candidate for epilepsy surgery? And this happens when seizures originate in more than one area of the brain, or when seizures originate in areas of the brain that cannot be safely removed. So we have what we call neuromodulation. Neuromodulation is a procedure based on the use of electrical stimulation to decrease the excitability of circuits in certain neuroanatomical structures of the central nervous system. This is something that has been used not only in epilepsy, but in the treatment of movement disorders and psychiatric disorders. And the principle of that is that when you exert certain stimulations, electrical stimulations in those circuits, you decrease the occurrence of the short circuits in the brain. Next slide, please. We don't recommend it in people who can be a candidate for epilepsy surgery, because epilepsy surgery is a curative modality. Neuromodulation is a palliative treatment modality. Palliative means that it will improve the seizure frequency, but the chance of achieving seizure freedom is low. And I will go over in detail over the different types of neuromodulation. The most frequently and oldest form of neuromodulation is a vagal nerve stimulation. And that consists of sending electrical stimulations. And you can see the stimulator that is placed in the chest, under the skin, in a muscle pocket, connected to a nerve called the vagus nerve. That is a nerve that travels in the neck between the carotid artery and the jugular vein. That nerve is a very thick nerve that is like a highway to the brain, and it connects to areas that are very important in modulating the excitability of those structures in the brain. And by sending electrical stimulations every 3 minutes, every 5 minutes, or every minute and a half, and the frequency with which this stimulation is delivered is titrated to individual patients' needs, can result in a decrease in seizure frequency in about 50% of patients over the course of 4 years. Only less than 5 to 10% of these patients can achieve complete seizure freedom in less than as I said, 5 to 10% for a period of 1 year. Next slide, please. The other is responsive neurostimulation. This is a different type of neurostimulation, and this is a modality that is used in people who have their seizure focus, or the area where the short circuits that cause their seizures in the brain originate in areas that cannot be removed, or where the focus are more than one in general, when they have two foci. Here, the stimulator is connected with electrodes into the areas of the brain that are generating the seizures. This stimulator has a computer chip that records the abnormal electrical activity, and when it detects the abnormal electrical activity, it sends an electrical stimulation that stops the seizure. And each electrode is programmed to detect the specific abnormal electrical activity from the seizure focus. With the responsive neurostimulation, the probability of benefiting is about 75 to 80% of patients will see a greater than 50% reduction in their seizure frequency over the course of 6 to 8 years. And about 15 to 20% of patients have become seizure-free for more than 1 year. Next slide, please. The last type of neurostimulation is what we call deep brain stimulation of the anterior thalamic nuclei. In this case, the person gets these modalities when the seizures are not well localized, or the person has more than 2 seizure foci. The thalamic nuclei are structures of the brain that can inhibit the excitability of brain structures that generate seizures. And by providing this stimulation, it enhances the inhibition of the abnormal electrical activity that causes seizures. The results have shown that about 60% of patients will experience a greater than 50% reduction in their seizure frequency, and about 5 to 10% can be expected to become seizure-free for more than 1 year. One of the important advantages of these neuromodulations is that they have a positive impact in other aspects of the epilepsy. Next slide, please. In the case of the vagal nerve stimulation, the next slide, you can use it in any type of epilepsy, and it's the least invasive procedure. And it also has been found to be effective in treatment-resistant depression. Depression is very common in people with intractable epilepsy, so that's an advantage. The other advantage of the vagal nerve stimulation is that patients notice that they recover faster from the seizures, and their thinking is more clear. So it improves their quality of life by this process. Next slide, please. Here you can see how easy it is to program the stimulator in the chest that changes the parameters of stimulation with the vagal nerve stimulator. Next slide, please. With the responsive neurostimulation, one of the advantages that has been found is that in people with temporal lobe epilepsy, where we often see a deterioration in memory processing when the seizures originate in the temporal lobe, we see that the memory processing does not worsen in people who've had implanted this device. And also, in about 8% of patients, there's been an improvement in their memory processing. So that's an important consideration. Both the vagal nerve stimulation and the responsive neurostimulation have been found to improve the mood of patients. They decrease the risk of sudden unexpected death in epilepsy, which is unfortunately an occurrence in people with intractable epilepsy that is higher than in the general population. And the risk of sudden unexpected death in epilepsy was found to be decreased significantly by both devices. That's an important advantage also. So we have to think not only on the seizure freedom, but also on the other aspects of the epilepsy. Next slide, please. And for the anterior thalamic nuclei, the same can be said. The impact on mood, however, is not being identified as with responsive neurostimulation and with the vagal nerve stimulation. However, the deep brain stimulation is now being used also for people with very severe epilepsy, such as Lennox-Gastaut, where the target is a different nucleus in the thalamus. And studies from Mexico and other areas have shown a significant improvement in drop attacks and those very serious seizures that can result in injury. Next slide. So the determination of which type of neuromodulation is going to be offered depends on the type of epilepsy that you have, where the seizures originate from, and how well localized the seizure foci are. Finally, the ketogenic diet and other diets have been used. Initially, they've been used very effectively in children, such as the ketogenic diet in children with Lennox-Gastaut. Now we're starting to use them more frequently in adolescents and adults, and the results are quite encouraging. But the data in adults is still very limited. So I'm going to stop here and answer any questions that you may have, and I appreciate your attention to this presentation.
Thank you, Dr. Kanner. And we do have a couple of questions for you. One of them is, at what point should I consider surgery?
You should consider surgery when you're being tried on at least 2 or 3 anti-epileptic medications, and your seizures persist, making sure that obviously you were prescribed the proper medication at optimal doses, and that your doctor has done an evaluation to make sure that the diagnosis was accurate. And the process of evaluating a person for surgery then should begin at that point. It doesn't mean that you need to have the surgery when you say, okay, I want to consider the possibility of surgery. You want to see what are your options. And because epilepsy surgery can cure your epilepsy, and as I said, if the seizures are coming from the temporal lobe, in between 50 to 70% of chances. And if you are a candidate based on a set of criteria, then you may want to consider at that point the possibility of the surgery. You have to consider the fact that if you continue to have seizures because of you're afraid of the risks of the surgery, you have to remember that in order for your doctor to recommend surgery, the risks have to be minimal, and you have to be found to be an ideal candidate. And at that point, you also have to ask yourself, well, if I don't do anything, what's going to happen with my seizures? And the problem is that your seizures will persist. Sometimes they can get worse, and there are other complications that can arise. So I encourage people to at least discuss with their doctor the options of epilepsy surgery and whether they are candidates, the chances of being seizure-free, and the risks.
Okay. And that sort of leads us into another question that we've gotten, and that is, what questions should I ask when considering other options instead of the medication, the patient?
Yeah, so the questions that you need to sit down with your doctor is to review, okay, let's go over my epilepsy. What type of epilepsy do I have? And you have to have a clear understanding of what type of epilepsy. What type of medications have we tried, and have we used the proper doses of the medication and the proper medications? So those are the important questions. And then comes the next question. Okay, it looks like I'm having seizures despite having tried 2 or 3 medications. And the likelihood that additional medications are going to render me seizure-free is less than 5%. So at that point, that's when you want to look at additional options. And for that, you need to undergo an evaluation that we call a pre-surgical evaluation that includes a VDG monitoring study in an epilepsy center where they record your seizures, they see where your seizures originate from, and they correlate that information with the findings of your MRI studies. There are other studies that are part of the pre-surgical evaluation. But at the end of the evaluation, your doctor can tell you, based on all of this information, it looks like you may be a good candidate for this type of epilepsy surgery, or no, surgery may be risky for you, but you may be a good candidate for neuromodulation. And the good news today is that for patients who are not a candidate for epilepsy surgery, a big percentage are going to be candidates for neuromodulation, which has a lot of advantages, as I indicated before.
Thank you so much, Dr. Kanner. Wonderful presentation. We appreciate it.
You're welcome.
All right. The Q&A box there. Good. All right.